Ladies and gentlemen, thank you for your attention. So thank you for your interest. I'm really glad that you are still here and show some interest on this innovation. What I would like to show you is a new research approach on the multidrug resistance transporters. These are proteins which are ubiquitously expressed on most of the cells and also on the immune cells as well. As you know, these are the three most important multidrug transporters, the MDR1, MRP1, and the BCRP. And these transporters are mainly known from oncology and also from the rheumatologic diseases or also other chronic inflammatory diseases. But in this way, our study is part of a broader development program where we would like to develop a completely new diagnostic device for measuring the multidrug activity numerically. So we quantify the functional activity of these transporters, and we hope to place on the market a new device in the coming years in both on chronic diseases and also on acute inflammatory diseases. So from this perspective, we are now conducting a clinical study on acute pneumonia patients, and hereby I would like to show you some interim results about this study just to show where and how we progressed. The measurement principle is quite simple. We have in the reagent kits fluorescent dyes with which we are loading the immune cells in vitro, and because these fluorescent dyes are substrates of these transporters, the transporters efflux the majority of the dyes from the cells, so the remaining fluorescence intensity can be measured by flow cytometry, and you will get these two type of intensity bars, as you see on the left hand. With the blue line, it is when the transporters are active and exporting or effluxing the dyes from the cells, and we are also applying inhibitors, specific inhibitors, which are really very selective for that particular transporters on the same population of cells, and in this case the transporters cannot efflux the dyes, and it means that the remaining dyes in the cells show the baseline fluorescence intensity. So from the intensity difference of the two population of the cells, we can quantify the transporter activity. So sampling the patients is really very easy because we need just peripheral blood samples, and then we can manage the assay within 2 hours from blood sampling. Regarding the clinical study, what is being conducted.
Yes.
The patients are admitted to the hospital within 24 hours. So patients are admitted to the hospital, and then we are enrolling the patients within 24 hours and taking the very first blood sample. And these patients are admitted to the emergency care unit. And we are measuring the two lymphocyte populations and also monocytes as well, isolated from the peripheral blood sample. We measure the patients at 3 time points, and we target to enroll relatively high number of patients. This is why it is just an interim analysis, and measure the MDR activity at 3 time points. On a patient level, not only the MDR activity are measured, but also several demographic and also vital parameters are recorded. Also, we measure cytokines, which are which are characteristic for the acute phase of the inflammation, and follow up the patients up to 30 days at the maximum. The pneumonia patients are enrolled in two particular cohorts. The severe patients are characterized by the PO2 and also by the Horowitz index. And the cutoff value for the Horowitz value is 286. So under 286, we consider them severe patients, and above that are the mild patients. And one of the main important or most important exclusion criteria that the patient should not have primer bacterial infection. So that's why the cutoff for PCT is set for 0.5 nanogram per liter. Also, we are excluding the concomitant steroid use because the steroids are known to influence the transporter activities, and also there are additional exclusion criteria which what I really do not want to go into details. Regarding the patient population, from demographic point of view, the population is quite homogeneous. On the other hand, there are several vital signs from which I hope you can read the slide, but I can highlight a few figures here that from this point of view, the population, both population, is quite heterogeneous. So there are several outliers, and this is one of the pitfalls of the study, obviously. As you see, from Horowitz point of view, the two patient cohorts is really characteristically different. However, we have obviously one patient here which was put in the wrong cohort, and because the patient visits are still ongoing, and we have really just a very limited sample size at this moment. So 32 patients has been enrolled so far, and then 4 of them are screen failures. So the statistical sample is at this moment is really very low. What is interesting that the grand majority of the patients are finishing the study within 6 to 7 days. So this is what you see on the very first histogram, that the 16 from the total patient number finished the study within 6 days, and until the D5. So the 5th day of the treatment, the patients usually improve regarding the disease status, and there are just a very few patients, there were 3 patients where no change was in the status, and 1 patient deteriorated only. So you are clinicians, so probably you can decide whether this kind of imbalance is notable, or it can be also somehow balanced in the future. We make a try at least. As the data cleaning and also the patient follow-up is ongoing, I can show you later on, maybe in the next year, some more data on that. A few words about the interim results. What you see here that also already on this very limited data pool, there are some trending differences there is no at all at this moment significant differences between the patients. What you see here that with the blue bars, there are the MDR activities in the severe and also in the mild patient groups. The orange one are with the MRP1 activities, and the green is the BCRP activities. And you see that in the severe patient pool, patient cohort, the at least seems to be a very more smaller activity in this MRP1 activities than in any other with any other transporters. For the cytotoxic lymphocytes, the CD8 positive lymphocytes, the pattern is almost the same. However, the average of the transporter activities are much higher than on the regulatory lymphocytes. And regarding the monocytes, what is obviously different is the BCRP activities in the mild patient group. However, these are still not significant differences. So we hope to see also significant changes in the new data coming from the new patients enrolled in the study. So this is what I can show you at this moment regarding this research. And of course, we hope to see more statistically significant differences in this regard, and hope to finish the study because of course, it is really an important part of the development program. We are still proceeding with the chronic phase, with the IBD patients, and also with the rheumatoid arthritis patients. And what is important that, for example, the JAK inhibitors, I know that they were also tried during the COVID pandemic as well. These are all substrates of these transporters. Of course, not substrate of all transporters, but for example, tofacitinib or baricitinib are both substrates of BCRP and MDR1 as well. So from that perspective, it's really interesting to see that these changes in the different lymphocyte populations or even in the monocytes might create some difference in the drug effect as well. I am aware of the patient, the patient's insert and patient leaflets, what is valid for these drugs, that there are at this moment no black box warning or any other warning for those drugs. But we would like to a little bit explore if there are any possibility to see therapeutic differences as well. So thank you for your attention.